Good morning and thank you in case you're just joining us. But if you've been with us since we started the show, thank you once again for keeping it Citizen Television as we shift gears and now focus on matters health. Being Wednesday, we usually discuss issues to do with how we are progressing when it comes to delivering healthcare services to Kenyans in a way that they deserve. And we want to just pick up the conversation on the universal healthcare. Just a few days ago, about 10 or 11 days ago, President William Ruto officially launched the universal health coverage. We saw this happening during the Mashujaa Day celebrations. But now that we are post the launch of that particular process, we now want to talk about the practical aspect of implementing UHC. What does this look like? And the government insistence on primary health care. Why is this important? And that is why we have in studio the man in charge of that docket at the Ministry of Health. I'm hosting this morning the Deputy Director, Medical Services, who also heads the Division of Primary Health Care in the Ministry of Health, Dr. Salim Ali Hussein. He's a medical doctor, has served as the head of the Department of Health Promotion, also the Division of Community Health, and also has been working at a particular point of his career as the District Medical Officer in charge in Marsabit, Makindu, and I can go on and on about your rich profile, Daktari, but allow me to stop there in the interest of time. So good that we have you this morning to talk about primary health care as a pivotal element in the implementation of universal health care. But before we get to what you do best, that is just helping us understand the primary health care concept, we are talking about the universal health coverage. This is sort of like the umbrella of everything that will ensure that Kenyans have access to health care. From where you sit, Daktari, how do you, explain to a basic person what universal health care means for them?
Thank you very much, Juan, for inviting us here to talk about health matters, especially the universal health coverage. So I think basically in a layperson's universal health coverage is trying to give people quality health services in a manner that they can afford and they should not suffer any financial hardship. Mm-hmm. Yes.
Yeah, that easy, that simple. That is what each and every person wants. But they usually say that it's easier said than done. And that is why we're here to talk about delivering these health services to Kenyans in a manner that you have described. And let's get to talk about this UHC journey. It's not the first time that we find ourselves having this conversation as a country. We've seen this under several, governments during the reign of the late President Mwai Kibaki. We saw an attempt to launch UHC. Former President Uhuru Kenyatta also did his part to make an attempt in launching UHC. We are here again talking about UHC just a few days after it was officially launched. One would ask, what is making this time different? What is it that the government is going to do differently this time?
Yeah, thank you very much. As you have correctly put, yes, it is true. Universal health coverage in Kenya has been launched or tried several times. And I think basically, one, those other times that it has been done, there are some lessons we learned, which we picked and which we are working on and improving. But more importantly, as you have put it, currently there are several things that are being done differently. Mm-hmm. One, there is a lot of legal reforms and processes that are being done so that we can actually ensure that this universal health coverage is being done. Some of these legal processes that are being done, we have the National Social Health Insurance, which now the President has assented to. Now it is an act. We have the Primary Health Care Act now, which also is trying to transform our health system into a more preventive and promotive health services. We have the Digital Health Act now. Most of the services actually currently, you'll see that the benefit, the access is increased when we use technology, when we use apps. That is something that we're also trying to do. Then there's also a facility improvement financing act that also has been assented and has been passed. This last act, actually, what it does, it will enable the facilities, whatever income, revenue they're generating, actually to be spent by them so that they can improve on their services. So there is a lot of legal reforms being done, which will enable to give it a legal mandate, but more important also, change the institutional framework that we have been working on. There are also other activities that the government, the ministry has been doing. For example, we have actually just assessed the services in 15,000 health facilities in Kenya, including public, private, faith-based. What we are doing is trying to see the level of service that is being given there so that we can actually know what are the type of services being given there, what is the expertise that is actually in that area. The government is also doing a quality assessment of those services, not just the services that are being done. And then we are also currently implementing the Kenya Health Act 2017, which is giving us a guideline in terms of the different levels of services that we have in Kenya. We have the 6 level, that is level 1, which is the community level, level 2, the dispensary level, level 3, the health centers, level 4, which is currently our sub-county primary health care facilities. Then we have the level 5, which are the county referral facilities. And then level 6, where we have very high expertise level, where we have for hospitals like the Kenyatta, the spinal injury, we have the Moi teaching, currently the Kenya University. So this in terms of what are the services supposed to be there, who are managing the human resource. Even in the Act brings about agencies or committees like the Kenya Health Human Resource Advisory Committee, which will be running the issue of the human resource actually in the whole country. So there are several preparations that are currently being done, either legally, institutional, so that when we're implementing the UHC, we are actually on the right footing. So that is basic, some of the things we are doing differently.
Allow me to take you back. Are you then saying that the lack of the legal structures is what majorly compromised the outcomes in terms of previous attempts to implement UHC?
It was one of the issues. Of course, we look at other issues, including human resource, commodities and that. But the legal aspect, for example, the Primary Health Care Act and also the current social health insurance, what it does actually now shows that some of the services like preventive and promotive, most of the time, which were not being catered for, the government is actually now ready to pay for some of these services at level 1, level 2, and level 3. So there will be publicly financed services from the government. Of course, we invite, we are supported by our partners, other donations, but first and foremost, the government, because this is their mandate and it is their duty, it has actually been put in a legal framework that the government will support, will pay for these services.
All right. I want us to explain the concept of primary health care, because we see a shift. The government is very passionate now in investing on what is now being called the primary health care. I know it's not a new concept, but why are we choosing to really go heavy in this direction this time around? What is the benefit or the significance of really, having a working primary health care system in the country?
Yes, it's very important first for all of us to understand the definition of health. Most of the time when people talk about health, the perception is that it's removing diseases, dealing with the diseases. But when you look at the World Health Organization definition of health, it's just more than the absence, a mere absence of diseases or condition. It is a well-being where it looks at the psychological, spiritual, even the economic aspect of that person. So it is a total system, well-being of that person. So with primary health care, which basically is giving services to people at the time that they need it, at the place that they need it, at a cost that they can afford, and also respecting their way of doing things, whether it is a culture, their area where they are. So it actually, now this deals with that person or those people has a person, not has a disease. And when you look at primary health care, there are studies, there are evidence that it is the best approach for actually to achieve universal health coverage. For example, in Kenya here, there are studies that have been done. If we implement our primary health care well, how will we benefit? One, there'll be more access to health services to the people, because people will be giving those services where they are. So you'll see that primary healthcare actually really focuses on bringing services closer to the people. And as you correctly mentioned, the president launched the UHC, and one of the things that at that time that was done was launching of the community health promoters. So we're actually taking health to the household. So afya nyumbani. The other thing that's been shown with those studies is that actually whatever we invest in primary health care, especially community-based primary health care, if you invest 1 shilling, you actually saving 16. So it is not just a capital investment area, but it's also saving which can be used to other areas. It has also been shown in those studies, when we implement this primary health care well and the way it is supposed to be done, in the next 5 years, we can actually save almost 21 trillion shilling. So there is a lot of effectiveness, efficiency in service provision, quality health service provision, but there's also a lot of cost benefits in terms of implementing primary health care. We also looked at almost 15 countries globally. How did they achieve their UHC? And one of the things that we found out is that they used primary health care. So we actually now we have customized our model on how to implement our primary health care.
Mm-hmm. And then how does this relate to universal health coverage? Because you're talking about going to the grassroots. Emphasis is on, really working on reducing the disease burden in a preventive approach and not curative. One would want to know how all this is connected to the country's journey to implementing UHC. Where does it fall, the primary health care?
Yeah, there's a lot of connection for us with the PHC leading to UHC, because PHC looks primary in terms of the initial need, the initial service that you need. So it could be at the community level, but even at the facility level, if that is the initial service you need, for example, you want immunization, it is in a facility, or you want an operation, but it is the initial. So even that facility, that it is still primary healthcare. But more importantly, primary healthcare, especially the model that we are using currently, what we are calling the primary healthcare networks, where we link the level 4 to the level 3, level 2, and level 1. It forms like a network where there's coordination between the human resource, that is the different cadres that are there. They work in a team that we call the multidisciplinary team. But more importantly, also these levels are made to talk to each other, to be coordinated. So the person in level 4 will be taking care of all the people who are being taken care by the health center, the dispensary, and the community health unit. And they'll also be looking at what are the services that we can actually take down. For example, if there's a nutritionist or a psychiatrist who is working at the level 4, they could work with the level 3, even with the community health promoters, equip them, capacitate them, build them, to know what are the basic, for example, malnutrition, what are the nutrition issues in the community that these community health promoters can take. The psychiatrists can also empower these community health promoters, basically for people to know what could be basic mental health illness, so that you can refer, so that people do not have complication. But more importantly, instead of many people going to the higher levels, one, if we implement the preventive and promotive, we reduce almost 80% of this condition. But also, instead of, for example, if we have 10 people who have chronic diseases, instead of them going to the higher level, the healthcare worker can actually come to the lower level. For example, from level 4 to level 3, where now you can actually now review, I can see this patient there, so it will be easier for those people not to go to higher level, and they'll be given services to that level. So primary healthcare actually looks at giving that services in an appropriate manner, more effective, and more importantly, take it to the people.
Mm-hmm. Take it to the people. But Doctor, you'll have to, look at also our realities on the ground. If you look at the local dispensary, the local clinic, in as much as there will be that increased awareness that will make people increasingly seek health services at this local level, if you don't find medicine in those hospitals, if you don't find the healthcare workers, in those hospitals, there are no equipment that will give you the services that you want, there will still be an influx in these hospitals that we are trying to decongest. So how will this PCN, plan work with these realities that we face on the ground, in our villages, in our communities?
Yes, what you have said is important, and it's a reality that once we have most of these patients, which already we are seeing, there will be a demand for more services. But initially, as I told you, we actually did some assessment of all our facilities. What are the services there? What are the gaps? Because when we were assessing this facility, we are looking at 6 building blocks. The human resource that is there and what is needed. The commodities that you are talking about, the health products and technology that is supposed to be there and that is needed, even the financing aspect, the issue of infrastructure. So all this has been assessed where it is possible, and we are really working with the COG and the county. We are already working on improving this facility. And one of the things that we believe will also improve these people to be well-equipped, well-salaried, and even increase the human resource is to have more revenue. And when I talked about the bills, the 2 bills that I talked about, the social health insurance, that will make sure that people who go there are actually covered, they are paid. The facility improvement financing bill, whatever revenue is being generated there, it will be retained there and spent. Currently, what was happening is that whatever they generate used to go to the central government or to the county, and most of the time it was not regenerated back to that facility. So there will be improvement of the gaps, one, but also the government now in the social health insurance. There are 3 finances actually there, and one of them is that they'll be paying services to those people, so the facility will be retained. But also the government is looking at how do we improve the issue of human resource? I had alluded to, there already now there's an advisory committee for health human resource. So where there are gaps, we are looking at employing almost 20,000 people, health workers. We are looking at improving the equipment and facilities. We are glad that previously there was a lot of equipment that was was actually sent to the counties. We are looking at how do we give capacity to some of the people where there are no people to use those machines. So we are looking at several areas that already have gaps and how they're going to be addressed so that actually the demand can be met by the supply.
Okay. I want us to look at the Primary Healthcare Act, the bill that was recently assented to by the head of state. This is actually what is going to sort of like bolster the implementation of the primary healthcare. I want to understand what is it in that act that stands out for you that, is going to revolutionize how we look at the primary healthcare system in our country?
Yeah, I think more importantly, the Primary Healthcare Act will change the way we are looking at things. Currently, a lot of our planning, our implementation, our programs are very diseased focused. They're very siloed. We are looking at a person, we are looking at a community it is a malaria community, or this person has malaria, or we need to deal with people with just diabetes or people just with hypertension. So what it's trying to do first is to maintain people who are healthy. So we want to protect that health that they already have. So there is a lot of health promotion. It is more promotive. So there'll be a lot of issues to do with lifestyles, living well, nutrition, issues to do with physical activity. So people being educated that they need to retain their health as one of their most important asset and one of their responsibility. Secondly, there'll be a lot of preventive aspect on the same, where currently, as we are speaking, some of the community health promoters will be looking at basic things like high blood pressure in the household. We are already seeing that it is making a difference. We have a community health promoters who have referred almost 11,000 people currently since it was actually launched. And most of these areas, we have seen that there are people who had hypertension, but they were still in the household. So there'll be a lot of screening. Then this Primary Health Care Act will enable what we are calling the primary healthcare networks to work together. The different workforce to work as a team. They'll be dealing more with the needs and priorities looking at the sub-counties. So because the Act brings about the issue of these networks, and we intend to have about 315 primary healthcare networks in the country, which will be covering a sub-county. And these specific networks will be looking at what are the specific needs, what are the specific priorities in those areas for those people, so that they can deal, because not everywhere is uniform. So this act actually will reorient our health system to a more preventive, a promotive health system.
So has the mapping already been done to interconnect these health facilities to sort of, come up with the PCN, structure? Is that done? Is that complete? And you have, at least, if I may call it that, of requirements for each and every facility? This is what is needed here, this is what is needed here.
Yes, the mapping, we usually have all our facilities in what we call our Kenya Master Facility listing. It lists all the facilities that we have. We also have what we call our community health unit listing. We have community health units at the community level that take care of certain number of a household. Ideally, each community health unit takes care of about 5,000 people. So already in our system, we had these facilities and community health unit. But now what we have done, or we have gone a step ahead, is actually organize those facilities into a network. So we have now the level 4s, which they're actually the sub-county primary healthcare facility, referral facilities. Now we have mapped or linked them to the level 2 facilities, level 1, level 3, level 2 facilities, and level 1. This is what we are calling the spoke. So we have the hub and spoke model that we are using. So now currently we are actually training all the sub-county workforce, the county health management teams and the sub-county health management team on now how do they operationalize these primary healthcare networks. So we have already identified them, we have already linked them. Now what we are doing is giving them the capacity on how to roll it out. And we're also going a step ahead that all these primary healthcare networks will be digitalized. So we'll have what we are calling a smart primary healthcare network. So our colleagues in the health information system and the Ministry of ICT we have already digitalized some of this PCN. So they are going around to see what is the gap in infrastructure to make these primary healthcare networks smart or digitalized, so that we can actually have the system. Already, the government, we have what we're calling the digital health platform. It's like a highway where different systems can talk and can be interoperable, so that we can have records which can be shared. We can have people moving from one facility to the other without taking their physical records. We can have e-payments from different levels, different counties. We can have telemedicine. This is basically giving services through a digital app. So we have already mapped them, but we have gone a step ahead now that we are training those people to operationalize them and make them smart. And for how long will we have to wait to start now seeing real takeoff of this? Because you say it's sort of like still initial stages? No, what we are doing is just improving on the same. Okay. It doesn't mean that they were not working, the systems were not operational, but now we are making them better. Where people, for example, were using a paper-based tools. For example, at the community health level, we had, they handed 1,000 community health promoters using paper-based tools. Now they're not using paper-based tools. Since the launch, they were given a kit, they were given smartphone. So now they're actually collecting that data from their household using their smartphone. So this data previously used to take almost 1 month before it was uploaded into our Kenya Health Information System. Currently, as we are speaking, it is actually going direct to our Kenya Health Information System. So that level we have. The other levels, now instead of them using paper-based, they'll be using a digitalized. Instead of them working in silo, and now the multidisciplinary team have talked, now it will be even better. So it is what they're doing, we are making it better and more effective. So we are not starting, but we're improving what they're
progressing.
Doing. Yes.
All right, let's talk about the community health promoters. You've actually kept on referring to them and what they are going to be doing in this particular process of implementing universal health coverage. The president actually, the Ministry of Health We saw the president the other day, should I say commission, because 100,000 community health promoters. And we want to understand, what their role is going to be on the ground. And also, one of the things that I had as a concern was the fact that some people were asking, 100,000 community health promoters, how are they going to serve a population of over 50 million people in the country? Just explain to us, how that is going to also pan out.
Okay, thank you very much. I just want to put it that our community health promoters, they have been commissioned, but this is not the first time they're working. We have been working with them since 2006. And this is a group of people that are actually selected, nominated by the communities themselves. And then they give us these details. We have them in our registry, but they're selected and nominated by the communities themselves. Once they're nominated, what do? We train them. We have around 14 modules that they take, very basic in terms of how they handle different conditions, which we talk about the technical modules. We also give them capacity in terms of health information system management, community health development. So ideally, these people, they're organized into what I mentioned, a community health unit. A community health unit takes care of about 5,000 people. So in the country, if we have 50 million people, and you divide this by 5,000, gives you around 10,000 community health units. And in each community health unit, we have 10 community health promoters. That's how we came up with the number of 100,000. Okay. So these people, then they are given, in that community health unit, they are given almost 100 households. We assume that each household has 5 people, according to the Kenya National Bureau of Statistics. So these 5,000 people, if you divide them by 5, we assume that there are 1,000 households. So each of the community health promoter in a month is supposed to register his or her 100 household, go and see who are the members there, which are the conditions they have there, and then educate them, more importantly, and if they see anything to be referred, they refer. So that is how we have come up with 100,000. So they take care of only 100 households. They will be different of variation, especially where maybe there is very sparsely densely populated areas like the arid and semi-arid areas, but also because of the geographical region. If the area is very vast, the person cannot actually handle 100 households in a month, so they will have fewer in terms of the movement and the coverage. So basically, these people, there are 3 basic function. Is one, for us to help us as a government, has the formal system. Wherever we have any health implementation, they are our entry. There are people who are known there. There are people who are trusted there. They will take us around. For example, whenever we have campaigns, we have had polio campaigns. When there was COVID, they were actually our eyes on the ground. They were our entry. When we move with them, we use them. We go to the communities, and they're there. They are accepted. They are known. So it becomes easier for those communities to own our implementation, because usually we want them to own this implementation. When we are away, there is sustainability. They will continue. This person will see that it is continuing. So that is one of the things. The second thing, more important for us with these community health promoters, why we take them through these different modules, which include family planning, include nutrition, HIV, TB, malaria. We have even household pollution. Is for them to give them this basic information, for them to know what do they do, how do they handle if there is a certain condition that is emerging. Then the third and more importantly aspect for us with these community health promoters is referring. So they need to refer wherever they suspect there is a problem, a child has maybe a disease, because in the system, the mobile farm that we have given them, we have what we are calling the electronic community health information system. It also helps them to do basic diagnosis. They can see a child who is having a fever, is breathing very fast. Using the system, it will tell you refer immediately. this condition should not be here, whether it is pneumonia or any other disease. So the referral is very important. And when I talked about the primary health care networks, in our Primary Health Care Act, we will request people to be registered in these networks so that when there's a referral, we know this is the line. There'll be no need for you to jump to go to the high level. You'll be attended to the level. If your condition cannot be attended, you'll go to the high level. So more importantly, these community health promoters, for us, they are our entry. They look at educating our people and more importantly, referring when needs be.
You know, what would be the justification from moving from the era of community health volunteers to community health promoters? There's a lot that has been done to change their way of work. You've talked about the roles, but then again, if you compare how it used to be back then and how it's going to be, going forward, that transition from community health volunteers to community health promoters, what does it come with it?
Yeah, currently we are glad that the government has improved what I can say. One, their working condition. Yeah. They are better equipped. We have what we call the Community Health Promoters Kit, which previously they didn't have. The President Commission, they handed 1,000 kits. So each one of them now has a kit that he can work with. So they have what I can say tools and equipment to work with. The government also gave them the gadget for taking information, which I had mentioned. Also currently, the promoters will be remunerated a stipend of 5,000 shillings, which they didn't have. The national government will be paying 2,500 and the counties will be paying the other 2,500. So currently, the community health promoters we have are better equipped, better remunerated, and they're more motivated than before. So we moved them from the just volunteering without giving them anything. They're not promoters, to what now the promoters. But also for them, we learned that they don't like to be called volunteers. Besides what the government has remunerated them, has equipped them, and made their environment better than before.
So no longer volunteers, but promoters, community health promoters. Yes. You know, when this conversation about community health promoters began, there was that concern that the government is really investing and focusing on community health promoters at the expense of the other cadres of the human resource for health. We are still having a shortage in the country. Some were asking, instead of employing more doctors, more nurses, more clinical officers, we are focusing so much on the community health promoters. I don't know how you take these concerns, and also are CHPs a solution on their own?
CHPs are not a solution on their own. They're part of the system. They need to work with the other cadres. They need to work with the other levels. And they actually have different functions and roles that they are doing. And it doesn't mean that because these promoters have been brought on board that the government is not looking at the other cadres. As I mentioned earlier, there have been a very recent assessment of the different facilities, what are the building blocks there, human resource gap. There is the Kenya Health Human Resource Advisory Committee that has been put on board to look at many issues, not just the numbers, but the quality of these people, the services, their promotion issues, what are the gaps. So I think it is just steps that we are doing, and we are looking at this level and will actually support the gaps that are already there in terms of trying to reduce the numbers going there, people being more healthy. So I don't think they're taking any person's role, or they're being put in a position that they're more important than the other people. We still need the human resource. We know that we're not even to the standard of a World Health Organization, but it's an issue that is being looked at. But we believe that everything has steps. UHC is also a step. This is one of the areas that the government has tackled now. It doesn't mean they don't want to tackle the rest.
If you're to look at the primary healthcare, system, and I wanted to talk about the ideal or the elements that make up a successful primary healthcare system. You've been in this docket, is it from July 2019?
Yes.
I know now you've understood the workings and looked at what we need as a country, where we need to get for us to say that we have successfully implemented a working primary healthcare system. What would it take us to get to that space?
Yeah, basically we'll be looking at the 6 building blocks.
Yeah.
We need to look at the human resource, as you have correctly put it, at the different level. What is the expertise that is needed there in terms of also numbers and also appropriately deployment. One of the things is that even with the few expertise or the human resource that we have, sometimes we find that it's very concentrated to certain areas, maybe the urban area. That is where you find. So they need to be actually an equity in terms of distribution, deployment of expertise. Where this is not possible, then the issue of telemedicine should come in so that people who do not have these experts, this human resource physically, but how can they get the same services at different places? For example, if there are no radiologists in a certain region, but there is a person who can take the medical imaging in those areas, like an X-ray, for example, it can actually be sent to a radiographer or radiologist in a different area where you can read it and send it. So human resource needs to be adequate, needs to be the correct distribution and correct expertise. Secondly, the issue of commodities, they need to be there. The supply needs to be there. Mechanism needs to be shown that they are available. Because if they're not available, what happens is that you might generate a demand. When people go and they don't get services, it will actually demoralize them. You will not get them at all. The issue of infrastructure is very important. Looking at not just the health, if I may call it, the health infrastructure, that is just equipment, but even issues to do with roads, for example, accessibility is very important. We know that access to health services might also be hindered by the physical access if people are referred but they cannot move, for example, if it's a pregnant mother. So we're also working with our colleagues in the non-health sector. We call them the enablers. For example, the Ministry of Road. How can we have access to all our facilities? We are working with our colleagues in the area of technology, the area of network. How can we have networks close to the facility? Because our technology, most of it will use a network. We are working with our colleagues in terms of electricity. How can we have electricity? So the issue of infrastructure in totality, and then the medical infrastructure, of course, is also important, which we are already looking at. Then the issue of the service provision that is being done, is it the correct one? Do we need a refresher? Do we need more expertise? Which we have done very recently, looking at that. The issue of health information, how it flows, how it is shared, is something that the Minute is very particular. I had mentioned that we have the digital health platform, which is basically like a highway that it can bring other systems and for them to talk to each other, can be interoperable. So we need to look at all the aspects for PHC, for it to be done. And I'm glad that even at the level of leadership, management, and governance, which is very important, now there's a lot of focus, importance, and urgency being given to primary health care. We have seen that the President has assented to bills that will actually support the same. The President has been launching the community health promoters. So already there's leadership, whether it is political, technical, at all levels. So all these elements need to work together for PHC to be successful. Mm-hmm.
There's one thing I haven't heard you mention that I also find pivotal in the successful implementation of this, and it was a big issue even during the health conference in Kericho, financing the health sector. Money is needed, and this has been a challenge for us as a country. In the current budget, the Ministry of Health has about 141 billion shillings, out of which 18.3 billion has been set aside for UHC. But this is still not enough. It doesn't meet like the global requirements for what needs to be set aside for funding the healthcare sector. How big a problem is this for us as a country, and what do we do to get out of this?
Financing is one of the building blocks for implementation of not just PHC, but universal health coverage. And it's something that when you look at the three bills that I've mentioned, actually, they're looking at how we will be financing our health sector. When you look at our social health insurance, when you look at the Primary Health Care Act now, when you look at the facility improvement financing, they're all focused on how do we increase the financing. I think what you're talking about, which we are committed and we are part of the Abuja Declaration, was the 15%. And I think with some of these activities, reforms that we are doing, it will actually increase the funding, because some of the things that we are funding now are intended to be funded, they're not used to be funded, and more importantly, to be funded publicly, like the primary health care level 1, 2, and 3. Actually, now it is clearly stated there that they'll be publicly financed. So that will also increase. Of course, financings, they're not adequate, but there's commitment to improve, and some of the reforms have been done. Will actually improve the percentage that we have actually putting into the health sector.
I hope that will be achieved, because without the required finances, that we may dream big, but if we don't have what we really need to implement our dream, then it becomes another challenge. I want us to talk about our culture, because now is when we really need to help the local person understand their role in, achieving positive health outcomes. It starts at the grassroots. They say afya nyumbani. What is the problem that has hindered us from, making this gospel reach to those people, making issues as basic as sanitation, as basic as eating a balanced diet? People would think this is actually, something that should be obvious, but it's not if you go to the ground. What is the missing link, Daktari, from where you sit?
Yeah, I think it is very true. There have been misalignment between what actually is health. I'll actually say that it is because of different level. One, even at the health sector level, you'll find that previously there was a lot of planning in terms of how do we deal with the diseases. In fact, we're also moving like a disease sector, not a health sector. So most of the planning, most of the communication, when you see even most of the campaigns or the advocacy, it's because it's a particular disease day, whether it is HIV day, whether it is TB day. I think now the refocus, and especially for us with the Primary Health Care Act, is that now we need to look at health first before people become sick and we deal with the diseases. So the refocus will be more of first maintain your health. So the education, the work that we are doing at the household level is actually now to just remind the people that your health, it is your responsibility first, and it starts at the household. Actually, health does not start at the hospital. By the time you go to the hospital, actually you don't have health. It's either you are going to retain it or to repair it. So more importantly, we should look at the first institution of health, that is, it is the household. That's why we are looking at this issue of afya nyumbani. So that we remind people, your eating should be the good nutrition. Your lifestyle, you need to walk. Issues to do, even psychological, you need to be social, you need to intermingle. So there is a lot of reorientation currently, especially in our Primary Health Act, so that people actually are focusing on their health, then on preventing diseases. I think the health sector has been one of the issues. But also, I think with our communities, especially as life changes, adopting to what we can say is modern, you'll find that people are moving away from the traditional foods, which are more nutritious, which are more important. We need to go back to our grassroots. We need to go back to our tradition, which is important. Finding people working 8 hours, most of us just sit down. We need to put aside, even if it is 3 times in a week, I'd spend at least 30 minutes exercising. If you can do more, that is better. We need to look at the well-being, not just when you're sick and go to good disease. So we need also to empower our mothers, who actually were our first health workers, because they're the ones who used to take care of us. Give them that empowerment, give them that capacity. You know that they're starting from zero. They used to do things, but maybe they're not doing them the correct way. Now we need to give them more education. They can take care of our people. But we also need to look at the other social determinants of health. We have seen that an educated mother, so education is very important, will take care better of than a mother who is not. We know an empowered mother, an empowered household in terms of economic aspect will actually get more health access than the one that is not. So also these other social determinants that make health better, we need to focus on them.
Mm-hmm. If you look at something else that I also want you to talk about, the significance of regular health checks. Africans, we only go when we are ferried to the hospital at the last minute. As a doctor, you've interacted with patients over the years, yeah? What would you tell somebody who's watching you this morning in the context of having regular health checks and how this can also really improve their health?
Yeah, it is very true. We are very poor at health checks. You'll find most of us, we don't go for basic things like, for example, even dental checks, ophthalmic, that is eye checks, rarely unless you are sick, even just to know the status of your vital signs, that is your blood pressure, the sugar level. Most of us don't. Even those who are covered by insurance, most of them, there is an option annually to go for medical checks, and most of them do not do. So I think it is very important, has a continuum of life, different areas. There are things that it is good for you to be checked, it's good for you to be screened. Even looking at the stage, for example, when a child is born, there's certain things that we should have, or we should know, or should be aware of when the child is born as a person, and you could check. For example, just looking at the back of the child along the spinal cord, if there is a swelling or there are some hair, it could potentially tell you there is a spinal cord problem. And that is something that we can just check. If a child is born and you look at the eyes and there is a shiny white thing, it could be a problem in the eye. It could actually be what we are calling retinoblastoma. So basic physical checks. A child's head, for example, up to 5 years, it's important for people to know how it grows, how this, we have areas that are not yet coming together. We call them sutures. Are they going back to each other or not? So basic things during birth. During childhood, the child, how it is growing, it is important for somebody even to know, is this the right stature? Is this the right height? When we are adolescent, what are the things that we need to be checked? When at old age, for example, the male, it is important for them to have a prostate surface antigen check, for them to be checked whether there is a prostatic cancer. For the women, it's important, basic things that they can be taught themselves. Breast self-examination, which can actually prevent a potential cancer or breast cancer to happen, which is something that you can be taught within 10 minutes and you know what to do. They can have cervical checks. So it is important, some of these things at different stages, for people to be aware and for people to actually to go and to be checked. So screening is very important. I'm glad that we have started some of these screenings, even the household. I talked about the blood pressure. This is one thing that we expect our community health promoters to do all over these households to check, so that people can get it early or can be managed early. All
right, all right. Your health is your responsibility. At least that's what I get from what Dr. explained. Yes, afya yako jukumu lako. You need to take responsibility of your own well-being. That is Dr. Salim Ali Hussein, the Deputy Director, Medical Services, who is also the head of the Division of Primary Healthcare in the Ministry of Health. He was here with us as we just talked about the universal health coverage and talking about the primary healthcare system as a pivotal part of implementing UHC successfully. Thank you once again, Dr. for your time, and thank you for watching Daybreak this morning. My name is Safina Cheng Oma. It's always a pleasure to do this for you. That's how we wrap it up here, but enjoy the rest of your viewing.